Hello. In the final installment of the egg trilogy, I'll be using the egg diagram to explain the pathomechanism of peripheral and central nystagmus. I hope you enjoy it. Thank you for your attention.
So let's think about a peripheral problem. Okay, let's say a person comes in now with acute lesion in the eighth nucleus. Okay, eighth nerve. Okay, a classic condition is vestibular neuronitis. Okay, sudden viral inflammation and damage to the eighth cranial nerve. So you put a thunderbolt across this eighth nerve. So what do you think is going to happen to this diagram? Okay, now if you just look at my face now, all of you look at my face now. So remember just now when I was talking to you, my head was turning continuously left and right, but I was still without any energy expended from my frontal eye field. I was still able to foveate on the camera without any effort because my vestibular-ocular reflex is working. Okay, so when I turn my head to the left, this one had more turbulence. When I turn my head to the right, this one had more turbulence. And the increased turbulence is then transmitted to the contralateral 6 nucleus to effect this horizontal eye movements. So, but at rest position, both the semicircular canal have equal amount of basal, BASAL, basal rate. Okay, they're firing at basal rate. When I turn my head to the left, this one had got more stimulus. When I turn my head to the right, this one has got more stimulus. Okay, at rest, both of them are firing equally. Now, what I'm doing is mischievously coming in and damaging this left semicircular canal system by cutting off the eighth cranial nerve or damaging it by viral inflammation. Eighth nerve is completely gone. Poof, gone. Okay, eighth nerve is gone. Okay, so now remember, these guys were firing at basal rate. Suddenly, this one is gone to zero. This one is gone to zero. Okay, this one is still firing at basal rate. This one is gone to zero. Now, as far as I'm concerned, as far as my brain is concerned, this is equivalent to what? This is equivalent to this damage of the left eighth nerve here, complete abolition of the signals from the left here, but this is firing at basal rate. It's equivalent to this firing more and this firing less, right? So what kind of stimulus does that? When my head turns my head to the right. When my head turns to the right, this one was firing more, remember? But now my head is not turning, but this guy is firing at basal rate. This guy has gone to zero. So as far as my brain is concerned, this is stimulus is equivalent to my head turning to the right. When my head turned to the right, what happened to my left eye? My left eye abducted, my right eye adducted. Correct? My right eye, left eye abducted, my right eye adducted. Okay. So now, even though my head is still there, because this guy is firing at basal rate, this is gone. My eyes are going to move as if my head turned to the right. When my head turned to the right, my left eye abducted, my right eye adducted. So therefore, even though my head is straight, still looking at the camera, my eyes are now going to drift slowly towards the left and the wall there. I'll be looking at the wall. Then I'll be thinking, oh my God, why am I looking at the wall? I'm supposed to look at the camera. So what do? I send a signal from my frontal eye fields, which are still working, send to the 6 nucleus and push it back to the camera because I want to look at the camera so I can continue talking to you guys. Correct? So I'll push my eye back voluntarily back, okay, or reflexly back to the camera. Now, the moment I finish doing that and I continue talking to you, what happens to this imbalance between the two? It's still there, right? This guy is still firing at basal rate, but relatively more than this one, which is firing at zero rate. So now my eyes are still going to get the signal as if my head is turning to the left, to the right. So my eyes are going to move to the left again. And again, my head will turn to the left. Sorry, my eyes will turn to the left. Then I'll be wondering, hey, why am I looking at the camera? Why am I looking at the wall again? I should be looking at the camera. So I'll bring it back to the camera. Okay, but once I bring it back to the camera again the stimulus is still imbalanced. And the imbalance is going to push my eye towards my left. And I bring it back, reflexly back to the camera. It's a constant struggle now. It's going to drift back to the left, and I bring it back to the center. Drift back to the left, bring it back to the center. Drift back to the left, bring it back to the center. Drift back to the left, bring it back to the center. Drift back to the left, bring it back to the center. This is going on. As long as the imbalance is there, this is going on. So slow phase, fast phase. Slow phase, fast phase. Slow phase, fast phase. What is this? Nystagmus. So this is the basis of peripheral nystagmus. Okay, so when people talk about peripheral nystagmus, they are implying that the nystagmus is due to pathology in the peripheral vestibular system. Okay, the peripheral nervous system, specifically the peripheral vestibular system. So the semicircular canal or its nervous connections are damaged. So in this case, the eighth vestibular component, the eighth nerve is damaged. So all signals from the left semicircular canals are lost. This one is still firing. So the eyes are going to behave as if the head is turning to the right. So it's going to drift to the left, and reflexly, I'm going to bring it back to the center. So I'm having a vestibular nystagmus. So this vestibular peripheral nystagmus has got a few key characteristics, okay, which you need to memorize, okay, in the past. But now, today onwards, you don't need to memorize because the vestibular diagram will teach you all the key characteristics of it. Number one, where is the fast component? Is beating away. Which is the disease here? The disease here is the left ear. And the fast component is beating away from the disease here. So by looking at the fast component, you know which is the disease here. So in this case, my head drifts to the left, my eyes drift to the left, and I bring it back to the center. To the left, bring it back to the center. So I'm bringing my eyes back to the center, away from the disease here. So the fast component is away from the pathology. Rule number one. Rule number two, because the imbalance is between the left ear and the right ear, no matter what I do with my eyes, whether I look to the left, look to the right, look up, look down, the direction of nystagmus will always be the same, because the imbalance is always the left ear not doing his work, the right ear firing at basal rate. So this imbalance is the same. So the fast component beating the right will remain the same whether I look to the left, look to the right, look up. It will never change and start beating towards the opposite direction. The direction of nystagmus is always the same. That's rule number two. Rule number three. Remember we said there were three semicircular canals, right? One pointing up, one pointing sideways, one pointing back. The other side, there are also three. So if the vestibular component of the eighth nerve is completely damaged, all the signals from these three are gone. All three gone. So the other side is predominant now. It's basal, but it's now 100% more than the other side because it's not gone to zero. So this guy is super dominant, and this guy is super dominant, this guy is super dominant. But this guy and this guy, if you look at it, the superior semicircular canal and the posterior semicircular canal, although it's about 270 degrees like that. One is going up, one is pointing back. Now, if you draw the vectors, there is some level of these two forces are actually opposed. The superior and posterior, because they are not direct. One is going this way, one is going this way. They are not 180 degrees. If they're 180 degrees, they will cancel each other out. But they are almost pointing against each other. So therefore, there's some level of cancellation of the vertical and the posterior downward component. But what is unopposed is the horizontal canal. The horizontal canal has got nobody opposing him. So he's the king. So you're not surprised that the component of the peripheral nystagmus is predominantly horizontal, because of the three semicircular canals that are remaining, these two are almost diametrically opposite. So they kind of cancel each other out. The only one that's not cancelled is horizontal. So the nystagmus is predominantly horizontal. But it's not 100% horizontal because unfortunately this guy and this guy are not 180 degrees apart. The superior semicircular canal, there's no inferior semicircular canal, it's posterior. So the superior is here and the posterior is here. So they are about 270 degrees. So if we draw the vectors, there is still some component to it. And that's why if you look carefully, as you would see in subsequent video, at the nystagmus, it's predominantly horizontal, but there is a little bit of a slight torsional component. So mostly horizontal, slightly torsional component. So three key features of horizontal nystagmus, you can work it out just by using the egg diagram. Number one, the fast component beating away from the ear. Number two, the direction of nystagmus can never change because the imbalance is always on one ear over the other. There's no business for the direction of nystagmus to change. Number three is predominantly horizontal, okay, with a little hint of torsion. Okay. Now, if you don't believe this or not completely convinced about the explanation, let's work out the other way. Let's say my right semicircular canal is now completely damaged. My right semicircular canal is not working. My left semicircular canal is firing basal rate. So as far as my brain is concerned, my head is turning to the left. But my head is not turning to the left, it's still looking at the camera. but my eyes are going to behave as if my head turned to the left. My head turned to the left, my right eye abducted, my left eye adducted. So now if you hold that position, okay, my eyes, even when I'm looking straight at the camera, my eyes are going to deviate to the right. Right eye is abducting, left eye is abducting. But because I'm conscious, okay, there will be a reflex movement back to where I need to see. So what I'm going to do, I'm going to bring it back to the center. But again, because the imbalance is there, okay, now this side is damaged, this side is firing, the eye should be pushed towards the right, and I bring it back. Push towards the right, bring it back, push towards the right, bring it back, push towards the right, bring it back, push towards the right, bring it back. Now you see the fast component away from the damaged ear again. So by doing this vestibular diagram, you can work out firstly that what is peripheral nystagmus and the three main key components of the peripheral nystagmus. Only the fourth key feature of the peripheral nystagmus is not completely explained by this egg diagram, but is explained by something we explained earlier, the so-called Romberg's phenomenon. So in Romberg sign in the limbs, when a person has got peripheral neuropathy or peripheral problems outside the cerebellum, the patient is very, very unsteady. But the moment he walks into the room and says, "Doctor, I'm very unsteady," but then you notice he's still able to manage. But the moment he closes his eyes, he'll fall. Then we call it Romberg's positive. It means that the pathology is outside the cerebellum. He's just able to cope using his vision to balance himself. Because if you use vision, you know the floor is always 180 degrees. Anything on the walls, the pillars should be 90 degrees to it. So I can use this to adjust my balance. Correct? So your eyes can use to do it. But once you close the eyes, you don't have that input. So therefore, even that cannot allow you to balance and fall. So in peripheral pathology, in the peripheral nervous system, in the spinal cord, the Romberg's is positive. But in cerebellar disease, which is the key orchestrator of all the inputs for balance, it doesn't really matter whether your eyes are open or closed because you're already going to be very unsteady. You're going to come in very unsteady because your cerebellum is not working. Whether you open the eyes or you close your eyes, the difference cannot be very dramatic because it is not the inputs that are faulty. It is the orchestrator of the balance himself is faulty. But if the orchestrator is working well, but your peripheral nerves are not working well, your dorsal column is not working well, then your orchestrator can then say, okay, let me take some information from the eyes. I'm using the eye information to balance myself. So that's what he's doing most of the time. But the moment he closes the eyes, then he got no balance and he falls. That's Romberg's sign. So in other words, the cerebellum is able to cope with the visual input. So likewise, peripheral nystagmus like this is very disabling to the patient. Okay, you talk to the patient, you tell you, oh my God, I'm going to vomit all over you. I feel very dizzy. Okay, so what the cerebellum does is that it uses visual inputs coming through the fovea, coming through the retina, through the optic nerve, and uses that information to suppress the peripheral nystagmus. Cerebellum can do that. It can reinstitute balance. Okay. Now, again, if you take away visual input, then the cerebellum has got nothing to dampen this nystagmus. So the nystagmus becomes even more prominent. So I call this the Romberg sign of the eye. So Romberg sign of the eye is another sign to indicate that the pathology, the nystagmus, is indeed peripheral because the nystagmus becoming worse without visual input tells you that the cerebellum is coping with peripheral input from the eyes. Therefore, the pathology must be in the peripheral nervous system because it's able to cope. But if it's a central pathology, which you'll see later, whether the eyes open or not, just like in Romberg sign of the limbs, the patient will fall, the nystagmus will look the same. Okay. Now, without talking too much, I better show you an example. Okay. So this patient has got mild horizontal nystagmus that's peripheral in nature. And you can see a little bit of a rotatory component. It's beating to the right when he looks to the right. But even when he looks to the left, it still beats to the right. But it's not very prominent. Okay. But the moment I close his eyes, take away visual input, notice his nystagmus is much more prominent. Much more prominent than when we first started off with. Subtle nystagmus suppressed by the cerebellum because this is a peripheral nystagmus. So just like Romberg's, when you close the eye, patient falls. In this case, when you close the eyes, the nystagmus becomes even more prominent. This proves to you that this must be peripheral. So this is the last rule of peripheral nystagmus. Fast component away from the side of lesion. Nystagmus always in the same direction. Okay. A mix, predominantly horizontal nystagmus. And lastly, rhomboid sign of the eye. So open his eyes, nystagmus dampens. Close the eyes, nystagmus gets worse. Okay. Now the next question you asked me is, how am I going to see nystagmus if the eyes are closed? So this patient's eyelids were very thin, so we could see it. For most patients, you try to close it, you can try, but most of the time you will not be able to discern it. So that's when some of you may have seen me carrying these glasses in my bag. So these are very thick magnifying glasses. Okay. Now this thick magnifying glasses removes visual fixation from the patient. So if you put on these glasses, the patient will tell you, I can't see anything. But you can see the eyes very clearly, but the patient can't see anything because it's so thick and magnifying. Okay. So with the magnifying glasses on, you notice the patient's vision is removed, remember? So it's like closing the patient's eyes. Notice the nystagmus is very prominent. Now, the moment I remove the glasses, no more nystagmus. Nystagmus? No more nystagmus. Nystagmus? No more nystagmus. This is almost like magic, right? So likewise, the next, I only have one video of this patient. Huh? Do you have another one? I have one. I'll show you this one as well. Huh? This is another patient with very subtle nystagmus. Okay, nothing to write home about. But the moment you put on the glasses, the moment you remove visual fixation, the moment you do a rhomboid sign, the nystagmus becomes obvious, proving to you that nystagmus must be from a vestibular pathology, not a central nervous system pathology. So nystagmus is present but not very obvious. Now we take away visual fixation. Much more obvious with the glasses on, right? So if you remove the glasses, then the nystagmus will disappear. So this is known as rhomboid sign of the eye. Okay? Okay, so now we're going to put it back down. Okay, so these are the key components. Peripheral nystagmus does not change direction, it's always in the same direction. Fast phase away from the side of pathology is mainly horizontal with a little hint of rotation, and it works with removal of visual fixation, so-called rhomboid sign of the eye. Okay, so now that we have talked about peripheral nystagmus, we need to know what is central nystagmus. For central nystagmus, we need to bring in a few more characters to our plot, a few more characters to our drama, and then I have to introduce one more element for you to memorize. Remember, there are two things this whole lecture you need to memorize. Number one was frontal eye fields across. Number two, we'll tell you in a moment. Okay. So for frontal eye fields to work on the 6 nuclei, the problem with the frontal eye field is frontal eye field is just like the frontal lobe. It's not a very fascist, very definitive sort of creature. It's a bit of a hippie. It doesn't give very discrete commands. It tells you if you feel like moving to the left, maybe you want to move to the left. That kind of stimulus comes down. Now, that kind of stimulus is not enough for the 6th nerve to move to the left side. So it requires a much more deliberate signal. For the deliberate signal to come through, it has to pass through a transformer station. Okay, there's a group of neurons in the pons which takes the signal, takes the intent, because basically it's just an intent from the frontal eye field, takes the intent and then converts it into a more practical. Okay, if you like, this is a bit of a hippie, this is a bit more of a right-wing fascist. Okay, so he knows exactly what to do. This guy only says, okay, maybe if you feel like it, move to the left. This guy takes the command, okay, you want me to move to the left? Okay, now let me just execute this action. So he takes the command and converts it. Okay, now the technical aspects of it, you may have learned it in physiology. You don't have to. Okay, the technical aspects may be a little bit more complicated. You don't have to go to that level. So that this set of neurons, this PPRF has got this set of neurons called the burst neurons. Okay, which allows the signal, the signal, the intent to be converted into a burst of signal. Okay, But for practical purposes, especially for us clinicians who are practicing doctors rather than scientists who are more interested in the physiology of it, we can actually simplify the function of this group of neurons as go there neurons. Basically takes the content, the intent from the frontal eye field and converts it into a signal. Go there. It takes a whip and says, go there. That kind of signal. Okay. So these go there neurons are it's discrete structures in various structures. For example, in the pons, there's a structure called PPRF. What PPRF stands for doesn't matter. Okay, it doesn't really remember. You don't really need to memorize all these things. Just need to remember there are structures that convert these signals. Okay, and they are go there neurons. Okay, now then there is this signal is then sent to the 6 nucleus. But the go there neurons by themselves cannot function because go there neurons is just go there. It's almost like the first gear of your car. It allows you to accelerate, but it doesn't allow you to maintain the position. Okay, so you need a second set of neurons called the stay there neurons. Okay, so if you allow me to illustrate, my right frontal eye field now is sending a signal to ask me to look to the wall to the left. Okay, now I look to the left. You saw how I moved so fast, right? It was almost like simultaneously I was looking at you, the next moment I'm looking there. So it's many degrees, degrees in microseconds. So super fast velocity. For that to happen, your frontal eye fields cannot function on their own. The signal must be converted by this group of neurons called the go there neuron. So the go there neurons is the one saying, oh, so my eyes are able to start from zero velocity, accelerate to a maximum. Can you imagine? Accelerate to the maximum. See how fast it is? So fast, right? So it accelerates to the maximum. But after it accelerates to the maximum, it reaches the target. It cannot continue to accelerate there, right? It needs a second set of neurons because accelerate, that means it will be like you're revving the car at first gear all the time. You need to switch to second, third, and fourth gear to allow the car to maintain the position, maintain the speed, maintain the velocity. So the second set of neurons is called stay there neurons. Okay, the technical terms is neural integrator. Integrator because you can see from the formula here, it fires on an integrated manner. Okay, integrated on the position and the speed of the eye movement. But we don't have to go into the details of it. Just remember that they're stay there neurons. Okay, go there neurons and stay there neurons. So how does it work? My right frontal eye field sends a signal. Okay, please try to look to the left. This signal is then converted by my left go there neurons. Okay, my right frontal eye field sent to the left go there neurons will send a signal to my left 6 nucleus. Go there, my eyes hook. Okay, but once it reaches the target, my stay there neurons will kick in and keep the eye there. The second and third gear, keep the eye there. The stay there neurons, okay, are also discrete nuclei, okay, dispersed through the brainstem, but also prominently represented in the cerebellum, the stay there neurons. Okay, large parts of the brain's cerebellum has got stay there neuron function. In addition, there are multiple nuclei, okay, that are scattered through the brainstem, which have the stay there functions. Okay, now you can of course learn the names of these structures, okay, that are responsible for neurointegration. But again, from a practical point of view, from a clinician point of view, you don't have to. But if you are really interested, you can go and learn them. Many of them have Latin names that sound like Harry Potter charms. Nucleus prepositus hypoglossa, for example. Okay, sounds almost like one of the Harry Potter charms, right? Yeah. So again, not important to remember the individual names because there are many structures like that. But important to remember generically, they are known as stay there neurons. Stay there neurons are scattered in the brainstem and in the cerebellum. So now, what I need you to memorize, just like we need to memorize the frontal eye fields are cross, not ipsilateral, cross, memorize that. I need you to memorize that for central nystagmus, the pathology lies in the stay there neurons. Pathology lies in the stay there neurons. So let's say now I've taken 20 tablets of phenytoin, okay, and my cerebellum is completely toxified by phenytoin, okay, completely screwed up. Phenytoin is a toxin to the high dose, toxic doses, not damages, but this causes disruption of your cerebellum, right? So let's say I took 20 tablets at one go, okay, and I became toxic from phenytoin, and my cerebellum is not working. So now my right frontal eye field says, look to the left. Sends the signal to my left go there neuron. My go there neurons in the brainstem are working well. Yes, they are working well. So I'm able to go there. Okay. But then my stay there neurons in my cerebellum are not working. So what's going to happen? Instead of staying there, it's going to drift back towards the center. But then now I'm very upset because now I'm trying to look at the wall. I don't want to look at you guys anymore. I want to look at the wall. I send a signal to through my frontal eye fields to my go there neurons. And why am I looking at you? So I will send another barrage of signal. Frontal eye fields will tell a signal, please go look to the left. My go there neurons will say, look to the left. Poop, it goes to the left. But my stay there neurons are still not working. So it's going to drift back. Frontal eye fields send a signal to the go there neuron. Poop, it goes back again. And then it drifts back. Slow phase. Comes back to the center. Then my frontal eye field sent through the go there neurons. Another barrage of signals. Pop, it reaches the target, but it cannot stay there. It comes back again. So what is happening now? Fast phase, slow phase. Fast phase, slow phase. Fast phase, slow phase. Now I get completely disillusioned looking at the wall. So I decide to look at the wall on this side of the room. So I tell my left frontal eye field to send a signal to my right go there neurons, to my right 6 nucleus to go there. So no problem, right? So I'm able to go there. But again, my cerebellum is not doing its job of staying there. So what's going to happen? After going there, it's going to drift. My left frontal eye field will send another signal to the go there neurons to push the eye there, and it drifts back. Now my left frontal eye field sends the go there neurons. My eyes go there, but cannot stay there because my cerebellum is not working, it's drifting back. Now what has happened now? Now fast phase, slow phase. Fast phase, slow phase. Fast phase, slow phase. Now, many of you would have realized there's something very remarkable. Just now, where was the fast phase? Towards the left. Now, where's the fast phase? Towards the right. And so, in other words, the fast phase, unlike our peripheral nystagmus, is not unidirectional. It beats to the left when I look to the left. It beats to the right when I beat to the right. When I look to the right. But if you don't believe me, I decide to look up. When I look up, no problem, because my go there neurons are working perfectly, but my stay there neurons are not working. So it's going to back to the center. My go there neurons will push the eye back to the top. Stay there neurons are not working. Come back to the center again. So now the fast component is beating up. Why? Simply because I decide to look up. And when I decide to look down at my feet now, I look down at my feet, my go there neurons are working, so I'm able to look to the feet. But because my stay there neurons are not working, it's going to drift back to the center again. Pump, drift back to the center. 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 So now it's beating down. So what is remarkable is, unlike peripheral nystagmus, which is unidirectional, always beating in the same direction. Now, when I look to the left, it beats to the left. When I look to the right, it beats to the right. When I look up, it beats up. When I look down, it beats down. So what is the term for this? Gaze-dependent nystagmus. Okay, so a classic peripheral nystagmus is gaze-dependent nystagmus, and the terminology gaze-dependent nystagmus illustrates the pathophysiology. Because remember, the stay there neurons are not working. So no matter where I look, I'm able to reach the target because stay there neurons are not working. It's going to drift back to the center. So gaze-dependent. Now, a synonymous term for this nystagmus is gaze-evoked nystagmus. Now, both these terms are very useful. Therefore, we keep both these terms because it's gaze-dependent because when I look to the left, beat to the right, left, look to the right, beat to the right, look up, beat up, look down, beat down, right? But it's also gaze-dependent because when I look straight at the camera, look straight at you, you would never have guessed my cerebellum is screwed up by any time. No nystagmus at all because I haven't evoked a gaze. Because only when you evoke a gaze, then the physiology, the pathology in the stay there neurons is manifest. So this gaze evoked and gaze dependent nystagmus. Synonymous terms, both useful terms to use so that you can understand the interlocking implications these names give to the pathophysiology of central nystagmus. Okay, so let's look at an example. So this is what the diagram will look like. Massive disorders, whether it's one of the nuclei in the brainstem which are controlling stay there functions, or a pathology in the cerebellum can cause this nystagmus. That's why you see central nystagmus very prominently in cerebellar disorders. Okay, like our patient that we saw last week at the tutorial, he had massive cerebellar disease, and that's why his nystagmus also was prominent. But we also thought that he could have a nystagmus in the brainstem, because in the brainstem, by chance, one of the neural integrators may have been damaged. If one of the neural integrators are damaged, then the go there neurons may be working, but the stay there neurons are not working. So you will get a central nystagmus. Okay. So this lady looks to the right, the nystagmus beats to the right. She changes her mind and looks to the left, and it beats to the left. Okay, but notice carefully here, when she looks, when she was looking straight, nothing is happening. Only when you evoke a gaze. So it's gaze evoked nystagmus and gaze dependent nystagmus. So this lady had massive cerebellar disorders from the genetic cerebellar disease. So she has central nystagmus. So you realize that the two types of nystagmus that we talked about, and we use pathophysiology of the egg diagram to explain them. And they're actually beautiful because the mechanisms are quite straightforward. Okay, one of them is dependent on the imbalance in the inner ear function, the semicircular function. Another one is due to pathology in the stay there neurons. Okay, two different pathologies. But why do we have to worry about nystagmus, whether it's peripheral or central? Just like Babinski's response. Why do we worry so much about Babinski response? Because when a Babinski response is present, we know the patient's weakness must be due to upper motor neuron disease. So similarly, when somebody comes to you with various complaints, like dizziness, okay, the presence of the type of nystagmus will tell you whether the patient has got a central vestibular disorder, a central disorder like a brainstem stroke, or a benign peripheral vestibular disorder like vestibular neuronitis. Both of them will come to you with dizziness, both of them will come to you with nystagmus. But by looking for the type of nystagmus, is it a unidirectional nystagmus that's beating away from the direction of nystagmus, that predominantly horizontal, that improves with opening eyes and disappears or worsens with closing of eyes, okay? Or is it a nystagmus that doesn't seem to make any difference whether you open or close the eyes, and that seems to be present only when you evoke a gaze, and it seems to change direction no matter where you look, keeps changing direction. It's so schizophrenic, left to the, look to the left, beats to the left, looks to the beat to the right. Then central nystagmus will help you decide whether the patient in front of you has got a life-threatening stroke or a benign disorder like vestibular disorders. So that's why we use the nystagmus, although we revel in the beauty of the nystagmus because the pathophysiology is so beautiful to understand, but we use it practically like the Babinski's response to differentiate between central and peripheral disorders. Now, the next question is, are there other forms of central nystagmus? Well, the most important form of central nystagmus is the horizontal gaze evoked or horizontal gaze dependent nystagmus that we talked about. Okay, that's the 99% of the nystagmus of central nature that you will see will be this. Occasionally, you will see patients with upbeat or downbeat nystagmus. Okay, now the pathophysiology of the upbeat and downbeat nystagmus is equally beautiful, but it's a little bit more complicated and perhaps beyond the scope of what you need to know now. Okay, perhaps I would ask you now to just postpone that for maybe another later date or a later point in your career when you're much more seeing much more patients with similar disorders, because as a general doctor or a general internist or an internal medicine doctor, most of the time you would have to differentiate a peripheral nystagmus from a central nystagmus of the horizontal gaze evoked type. Okay. Now, occasionally when you will see a predominantly upbeat or a predominantly downbeat, just upbeat or downbeat at primary position, it is also central. Okay. Its mechanisms are beautiful to explain also, but just that, as I said before, it will take me another half an hour to explain, and perhaps we don't have to go to that level of detail because it's not common. Okay. So this patient, you can see at primary position, okay, at primary position, it's already beating down. Boom, 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 like a ping pong ball, it's beating down. So this is what we refer to as a primary position downbeat nystagmus. Another example would be this lady who's got a classic lesion in the craniocervical junction. You can see primary position downbeat. Okay, primary position downbeat nystagmus. Okay, this patient with cerebellar disease from cancer of the lung. Can you see? Pump, pump, pump. Fast component down all the time at primary position, downbeat nystagmus. Okay. So all these patients that we talked about, definitely central. Okay. Okay. Finally, what about upbeat nystagmus? Remember, vertical is upbeat, downbeat, or central. So this patient has got a brainstem midbrain lesion, and the lesion is causing a predominantly upbeat nystagmus at primary position. This patient has got a classic central nervous system pathology due to Wernicke's encephalopathy, an important condition you need to know, because you can cure these patients with high doses of thiamine, and if you recognize it, so if you recognize his, you can see his beating nystagmus is boom, 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 beating up all the time. Okay, upbeat nystagmus. Okay, so the second part of the talk, we talked about two types of nystagmus: peripheral nystagmus, and we went through the key features. None of it need to be memorized as long as you can do the vestibular dance, okay, right in front of you, and that will tell you that it's due to an imbalance in the vestibular system. That's it. So this imbalance can only give you certain key features, and the four key features we talked about. Okay. Now, central nystagmus, on the other hand, is gaze dependent or gaze evoked, both are synonymous terms, and the pathology is due to stay there neuron dysfunction. The stay there neuron dysfunction can be either in one of the nuclei scattered in the brainstem or in the cerebellum. Okay, and this is the part that you need to remember, that central nystagmus is due to stay there neurons. Vertical nystagmus, we didn't talk about the pathophysiology, but it's again something very central. But as I've said many times to my students before, if you one easy way to remember vertical nystagmus as central in nature is that, remember, if peripheral nystagmus is due to imbalance in the inner ear, what kind of imbalance in the inner ear can give rise to this symmetric up or downbeat nystagmus? Impossible. Okay, because remember, imbalance of one ear over the other gives rise to this nystagmus that we just talked about, fast component away from the component. You do the vestibular dance. Okay, it could. If you selectively went and cut off posterior semicircular canal here, posterior semicircular canal here, and only allowed the vertical semicircular canal to function on both sides, then perhaps a peripheral disease can cause vertical nystagmus. Likewise, if you cut off both the superior semicircular canals on both sides, the only thing that's working is the posterior semicircular canal on both sides, then maybe you can call it downbeat nystagmus. But for that to happen, you must have a very sinister surgeon who goes in and just cuts off these two semicircular canals on both sides. Nature doesn't do that. Okay, so therefore, vertical nystagmus cannot be due to a peripheral pathology because it's so difficult to selectively involve symmetrically only the superior semicircular canal or the posterior semicircular canal selectively. Okay, most of the time the pathology involves all semicircular canals of one side. So therefore, vertical nystagmus can never be peripheral, always central. Okay, and that's the summary for the last part. Okay, I hope I've convinced you that nystagmus is indeed, eye movements and nystagmus is indeed beautiful, and you don't need any memory work for it.